Hello, everyone, and welcome to Becker's 2021 Shift to Digital virtual event. I'm Erica Carbajal, writer and reporter with Becker's Hospital Review, and I will be your moderator for today's session, The Essentials for a Long-Term Virtual Care Strategy that will add to the bottom line. So as we all know by now, the COVID-19 pandemic dramatically accelerated the adoption of virtual care across the country's healthcare organizations, with eased restrictions on telehealth, making it more accessible for both patients and providers. But now, as we largely re-enter in-person care, what will sustainable virtual care strategies look like? Today, I'm joined by four excellent leaders to discuss how their organizations are navigating cost-effective long-term virtual care delivery. So before we dive into the discussion, I'd like to invite each of our panelists to briefly introduce themselves and share a bit about their organizations here. Sarah, do you want to start us off?
Sure. Thank you, Erica. I'm Sara Vaezi. I'm the SVP of Digital and Growth Strategy within Providence. Providence is a large integrated delivery network in the Western United States. We cover many states from Alaska all the way through Texas and New Mexico and many in between. We are very large in terms of our geographic footprint, as well as sort of our both horizontally and vertically integrated nature. We have over 50 hospitals, over 1,000 ambulatory sites, and we operate a university and a high school. We do a lot of work in supportive housing. So very broad in terms of our scope and footprint. I'll just say by way of telehealth, we've deployed telehealth across a number of use cases within our system, and that really accelerated over the last 18 months, in particular at the start of COVID. And so we can talk a little bit more about that, but I'm very excited to be here today. Thank you.
Thank you for being here. Abby, do you want to jump in next?
Sure. Hi, my name is Abby Lutz. I am the Vice President of Digital Care Operations, as well as the Chief Nursing Officer for OSF Healthcare On Call, which is the digital health entity within our 15 hospital integrated healthcare system. We largely support the state of Illinois, ranging from the metro area of Chicago all the way down to the border against Missouri and all the way over to Indiana. Also have a hospital in the Upper Peninsula of Michigan. Much like Providence, but smaller, we are fully integrated both horizontally and vertically with many locations, and have really carved out our telehealth strategy to a standalone entity or a hospital without walls that sits within the system.
Great, and Judd? Oh, I think we got you on mute.
We do. I'm Judd Hollander, and I still have not learned to unmute when I do telehealth or Zoom calls. That's sad. Anyway, I'm the Senior Vice President and Associate Dean at Thomas Jefferson University and Sidney Kimmel Medical College. And when I took this role, we were like a little baby health system of only 3 hospitals, less than $2 billion in business. And I was charged with beginning a telehealth program. And we have since done multiple mergers and acquisitions. And when we finish our most recent one, we will be up to 18 hospitals, which gives me the unique opportunity of I've rolled it out in one system and then 5 or 6 other systems, each of which that had different cultures. Compared to Sarah and Abby and Lisa, I'm in just 2 states for the most part, Pennsylvania and New Jersey, but we get to have fun with the rules and regulations regarding telehealth in at least more than one state to experience the pain that everybody else doing telehealth does across state lines.
Absolutely. And Lisa, last but not least.
Hi, everybody. Thanks, Erica. I'm Lisa Finkelstein. I'm a urologist and the medical director of telehealth at our teeny weeny little hospital compared to you guys in Jackson, Wyoming. I do sit on the board of the NRTRC, which is the Northwest Regional Telehealth Consortium, which incorporates Abby's or Sarah's area. And it's interesting to hear, what's going on in the Northwest area. But Wyoming, where I live, is truly rural. And we have different problems, similar but different problems than the other folks that I'm joining. And so it's fascinating to, hear what a major institution is doing versus, a little tiny rural hospital and a very rural state in Wyoming. So it's very challenging.
Great. Thank you so much to all of you for giving us a look at your backgrounds there. It's always helpful for attendees. So we'll go ahead and get started with the first question here. So can you each provide an overview of how your organizations are thinking about virtual care in and I put this in quotes, a mostly post-COVID world? I know, COVID will probably be around forever, but in a post-pandemic world, how your organizations are thinking about virtual care. Abby, did you want to start us off on this one?
Sure will, thank you. So I often describe this when I talk about it as our telehealth solutions were mainly project-based before COVID. And then COVID hit. So as we were trying to figure out how to spread, how to scale, how to introduce telehealth solutions as tools for our patients, we were quickly hit with pandemic response, which changed everything. So now moving forward, we're really looking at this and how we integrate it into everything that we do in healthcare. This has now become an access point for our patients that we see as valuable, but also that has become an expectation of them to us in how they access us for care. So really, we look now at our solutions as very holistically, as being a nice hybrid model of when to know when we need to physically see patients and what we can do virtually. We also are looking at how to introduce additional tools and technology to really create a very streamlined continuum of care for our patients, and looking at how we do that in all of our settings, from our most acute hospitals, our busiest tertiary quaternary care centers, to our rural hospitals and critical access facilities. So really looking at how we now take all of the momentum and lessons learned during pandemic response and translate that into how we deliver healthcare every day for our patients.
Absolutely. Yep, Sarah, go ahead.
Sure, I can add a little bit to what Abby said because I think it's highly consistent with how we're thinking about it, which is that we think that the future of care is multimodal, multi-venue, and that kind of hybrid, as Abby articulated, care is really the future. Now, there's a long way to get there from where we are now, which is relatively, I would say, sort of narrow scopes of telehealth that are either substitutive in nature, so you just swapped out like a physical visit for a virtual visit, or they are end-to-end, but within one specific type of service, like an on-demand or high velocity care type of situation, but that ultimately multimodal, multi-venue kind of care is the future, and it should be applied to, I would say, both, care that is delivered offline but digitally enabled. So for instance, through things like omni-channel scheduling and things like that, as well as truly online care that is video or asynchronous or text-based, or however you want to call it. So the degrees of freedom in the world is becoming a little bit more complex as a result of this multimodal, multi-venue kind of approach that we're heading toward, and it's creating some new challenges that I think are pretty interesting that we can talk about, but that's where we think things are headed. And as I said, there's a long way to get there in terms of like determining both at points in time as well as across patient journeys, for instance, what is appropriate to be delivered digitally versus physically. And so there's a lot of operating model, clinical model, payment model implications for all of this, but we're slowly heading in that direction because we definitely think that's the future. And I think not just from a Providence perspective, but we're also seeing that happen quite a bit in the market, as digital as well as retail disruptors really impact the way that individuals access care.
I just want to add, I mean, there's not much, I wouldn't change anything Abby and Sarah said, but I want to add one thing. This is our chance to reinvent care. And I like to say now, let's quit reimagining it. We had an imagination before COVID, then our imagination went away. And poor Abby had to create all of this based on some projects beforehand. You know, we had a large, robust program before then that the terms we used were right size, because we thought we would scale up when we hit value-based care. We didn't think we would do it over one weekend in March 2020 when COVID hit, but we had the groundwork laid for it in a different manner than many other enterprises. But what I hate hearing is comparisons to in-person care, because this is our chance to redo this. And all of you and every listener has been to a doctor where they went to the doctor and weren't examined by the doctor. They spoke to them, they shook their hands, you know, maybe they patted their shoulder when they walked in and out of the room, but they didn't really have an exam. We don't need a physical exam as people think of it, with pushing and prodding for every patient, for every condition. And I take as an example the one that people will think is, you know, the most objectionable right away: a cardiac patient. If you have a heart attack and you don't have a murmur and you don't have heart failure and you don't have symptoms and you're seeing the cardiologist, pretty close to never have they discovered a new murmur or asymptomatic heart failure when you walk through the hospital building. So what they're really asking you about is, are you having chest pain symptoms, you know, and other cardiac symptoms? But the physical exam doesn't make a difference then. So we need to not anchor all of our visits to doing things we did that were low yield in person and now translating them to telemedicine. That's not to say you don't need remote stethoscopes or remote otoscopes or pulse oximetry. You do for some patients, but we need to get out of the mode of thinking we need it for every patient. And this is really a great chance to recreate excellent care without doing all the wasteful things we've done routinely.
Absolutely. I think you raised some great points there about what telehealth will work well for and what it wouldn't. And Lisa, do you have anything to add here?
The only thing that I would add is to what Judd is saying. So because I'm a physician, I'm going to be the skeptic in all this. And that's really the group that we need to talk to, because a lot of this stuff, you know, us as the champions of telemedicine get it, but there are many, many physicians that are really still struggling, even a year and a half later, to grasp all these multimodal, multi-venue, whatever fancy language we're going to put to these things. And really, they want it to be easy. And also, they are very used to having face-to-face touching patients. So I think one of the biggest challenges that we have post-pandemic and you know, maintaining this momentum and not having to redo everything, but redoing care is a major hurdle, because most of the physicians out there are traditionally trained. And so my thing is post-pandemic, and Jefferson is one of the leaders on this, is to teach the new students coming in the new skill set of what the new care is going to be. And I'll leave it at that.
Okay, can I add to what Lisa just said with respect to the training? Because this is so important and gets lost. When you get trained in anything or almost anything in medicine, there's people who can mentor you, who could teach you, who know how to do this. And what makes telemedicine difficult, it's kind of like when your institution goes up on a new electronic medical record. I could go into an institution that has an EMR, get no training, and sit down next to someone who's well-trained on my first shift, and they'll teach me to do what I need to do to get through the first shift, and I can learn on the job. In telemedicine, no one knows how to do this or knew how to do this in advance. So if you don't train the med students or nursing students, who are kind of a captive audience, they're not going to learn on the job from physicians who are just out for a couple of years because they don't know. So in telemedicine, we need to train the newbies, we need to train the mid and early career, and we need to train the late career. And no one could look at the person next to them to get that training. So they plod through it together. So having robust training programs at all levels, Lisa, I think you nailed that. That's a hugely important point.
Another question I guess I would have for Lisa and Judd and Abby as well. One thing we're thinking through is, to the point that Lisa made, that providers need this to be easy. And we're introducing kind of new language, new technology, new models. And one of the things that we found is that's a lot to ask, right? Like you're already running your practice, and now we're saying, okay, and by the way, do this other thing that's new in addition to that. And that's just a general question. Like you can't just, turn on telehealth for all of primary care without changing anything else and doing the things that Judd was describing around truly transforming care. And so we're really thinking through, like, what does that actually mean? Do you pick a small part of your organization and just transform them, or hire in new providers into a specific line of service and do that from the start with them? And then what do you do with the rest of your system? And so those are like some of the questions that we're just grappling with, that I think will have a lot of impact on our long-term success and whether we're actually able to do this and maintain the momentum that I think Lisa and Judd both referenced as well. So that's just some thoughts that we're having and that we're working through right now. And if other panelists have an opinion on that, I think that would be really interesting to hear from you.
Sarah, I do think, like Judd said, if physicians are really honest with themselves, and again, it's very difficult for us to break our old habits and our traditional way of thinking, that most of the visits don't require a physical exam or a hands-on. And that I find is really hard to teach an old dog new tricks. Like they can learn how to do video visits because they're used to talking to patients, but the philosophy that they have and how they're thinking is really has to start from the newbies, as Judd said, from the school. And so therefore, teaching older physicians how to think differently, that's going to be a bit almost impossible, really. I mean, they had to do it because there was a pandemic. So, I think it's great that we're all starting to think about, how is this going to really, really look moving ahead into the future with new pharmacists and therapists and, speech, and it just covers every aspect of healthcare in telemedicine.
Absolutely. I think you all raised excellent points there. And Sarah, what you said about how everything moves so quickly. And so I imagine it could be frustrating for physicians when you're trying to learn one aspect, but then you constantly have these new initiatives being rolled out before you're even comfortable with the last one. So a lot of moving parts and challenges there. My next question here is, so a Frost & Sullivan report from earlier this year had predicted that 35% of patient interactions would be digital in 2021. So now we're a little more than halfway into the year here. So what does this look like at your organization? Where does your organization sit with that prediction of 35% digital? Abby, did you want to start on this one?
Sure can. By prediction, we were hoping to achieve about 15% of total interactions being virtual for FY21 year. However, I would say that's by definition. So if we would envelop some of the modes that Sarah referenced earlier around asynchronous or self-service channels, we're probably closer to that 35% mark for sure. I think that, one thing we did in OSF Healthcare was adopt virtual clinical interactions as one of our key metrics and pillars for our healthcare system. So it's one of the success metrics that accountable for throughout the year. So this has helped with some of the topics that we're referencing around, how do we introduce this? How do we get people engaged? And how do we create a level of accountability to change the way that we're delivering care, as Dr. Hollander mentioned earlier, across our healthcare system?
So Abby, I have a question for you, a follow-up, because I was wrestling with this today. You know, we had before COVID, we had metrics which were, clear and easy to define because people had to do a handful of visits, like really X% of the department had to do 12 visits and X% had to do 20 visits in a whole year, just so they knew how to do it. Right now, pretty much you do that in a morning, right? So everybody knows how to do it. And my team wants to set metrics that are, 15% of visits. But I have no idea what the reimbursement is going to be. And we just dropped a couple $100 million last year. And so I don't need the incentive to teach people how to do it, but I don't want to incentivize them to a made up number that could have negative fiscal impacts depending on reimbursement. On the other hand, I don't want things to go to ground either, as we know payers will take every opportunity to stop paying, at least until they're forced to pay. Do you going forward have a minimum number that incentivizes departments, or how are you dealing with it?
Yeah, that's a great question. So as we make these assumptions and look forward at how we set our metrics, we really look program by program. Our definition is really defined by clinician to patient interaction to start. So it needs to be an interaction between a clinician and a patient that's done on a digital platform. Then we dive a bit further to your point exactly. Which programs do we know that we're going to get reimbursement for, and what can we realistically predict or expect in those areas? And that's where you really get to the provider expectations. And then we have a whole host of virtual clinical interactions where our business case looks different. Maybe it's achieving economies of scale. Maybe it's caring for our at-risk population or full risk populations through remote patient monitoring programs. And so really it depends on the program and how we make sure that that is both financially viable for the system as well as a realistic prediction of number. We have not yet gotten to the point of requiring a certain number, but really the percentage overall, with the numerator being those virtual clinical interactions and then the denominator being all interactions, because to your point, not all of them at this point are reimbursable.
Thank you, Dr. Hollander, for that follow-up question. That's a helpful way to see how those incentives are working there in practice. And Sarah, how does this look like at Providence in terms of the percentage of patient interactions that are digital?
Yeah, and so I'll preface this by saying we had fewer than or less than 1% of our total ambulatory care was being delivered via virtual mechanisms prior to COVID, and then in the early months, March, April, May, it spiked up to around 65% for a number of reasons, partly because a lot of clinics were not doing in-person operations, and we just needed to continue to deliver care, and there were a lot of folks that couldn't risk the exposure, et cetera. And so we spiked at around 60%, 65%. We're now under 20% total. There is no organizational mandate at this point to say what percent we're trying to hit, partly because it's not necessarily an objective number. And if it were an objective number, I think to both Judd and Lisa's point, it would probably be a lot higher than 15, 20%. What we can actually do from a clinical appropriateness standpoint is probably relatively high relative to what the operating model and what the payment models would allow us to do currently. So I think that's more the question that we're trying to figure out is how do we start transforming certain really important parts of the business, and then making the kind of business model, the payment model work around that. And I think one of the key points that I think we're trying to work through right now is that I mentioned the word sort of substitutive earlier. This is not just about switching out physical for virtual. It's as Judd described, a redesign, and doing that redesign is not just, it's very challenging when you take it service by service and you look at the payment models and you overlay all the dependencies. So So that's where we're at now. And the one area where I will say that is a bit different for us is in the domain of on-demand or high velocity care, whatever you want to call it. These are like the urgent use cases. And that is, I think it has different attributes in terms of how patients are looking for that care and the providers that we specifically hire in to deliver that care. And so for that, it's, we're delivering thousands of visits through that platform that is much more seamlessly sort of integrated with our physical retail locations and things like that. So it's a bit of a different model than your standard issue, I would say, ambulatory care.
Yeah, I would second that completely, Sarah. We have seen the most success in that exact area as those urgent care models and how you integrate that in. I think that, it's very telling of the patients and where they immediately see value in those on-demand services too. So that's a great point.
Lisa, did you have anything to add here?
Yeah, we looked at our numbers recently, and the one specialty that has continued to remain very, very high with telehealth, bless you, Sarah, is telemental health. We're still hovering at about 80 to 90%. We only have one child adolescent psychiatrist, and he started, right around the pandemic, took over from another psychiatrist who was older, who dabbled in telehealth prior. And he has continued to have very, very high numbers for telehealth. All the other specialties have dropped down consistently to what these guys have said, to about 20%, but it is provider dependent. We don't have metrics that we put on physicians because we are a difficult bunch, and that just doesn't sit well with a lot of doctors when you say you have to do this. And then in regards to reimbursement, Wyoming, we don't have, a whole laundry list of payers, thank God. So we can keep a finger on the pulse of what reimbursement is. But that is also, we have a new CEO, and of course, they're worried about the bottom line. So it's all about what the payers are paying and how these things are going to reimburse. And so that is my job, is to try to keep track of how this is working in our state and also in the federal government.
Absolutely. There's a lot of controlling the controllables there. And I'm glad you brought up reimbursement. And I know we touched on this a little bit earlier, but how are you all navigating the virtual care strategies in the absence of that information on how telehealth will be reimbursed in the long term?
We're just taking care of our patients. One of the visions for Jefferson is place patients first, and we're just doing that. And the idea, as long as we're right sizing it and somebody doesn't pay for a couple visits here or there, it's not a big deal. If we were still doing 90% of our visits and they were unreimbursed, we would be doing 0 visits because we wouldn't exist. But right now, from the highest level on the enterprise, it's like just place patient care first, and we'll work out the finances along the line. And I think that's all we can do right now.
We have a lot of challenges in Illinois around reimbursement, even though legislation has been passed. I'm sure, as in many states, we still have yet to see how that legislation will particularly be implemented at the payer level and at the local level. So, first we start with what we know versus what we don't know, and really shore up programs where we're certain about the reimbursement. And then second to that, we really have started to develop our external sales strategy. How do we work directly with large employers in our service areas to provide some of these things for them? And then how do we work directly with payers? So have started a lot of that work with the larger payers in our area, our own covered lives, and how we have those conversations. So have kind of taken more of a roundabout approach in going directly to employers and payers in the interim, until we have some of these legislative things executed upon.
Sure. And Lisa?
Yeah, so Liz Cheney is our congresswoman, and she is introducing telehealth bills. I can't remember what it's called, but a big one in Congress. And so I've written to her, I've spoken to her, and it is really important to stay engaged with with your lawmakers, with your Congress people. And from the very beginning, even pre-COVID, I would talk to my patients about engaging with the payers and their legislators, which are our neighbors because it's Wyoming, and let them know what they like about telehealth. It's important to hear from the patients. It's important to hear from the providers, not just from the hospital, big systems and CEOs. So that's always been important. I also, I'm speaking to the choir here, but as long as our healthcare system is fee for service, do more to patients, bring them to the hospital, get them CAT scans and MRIs. It's such a messed up system. Let's just be real and honest. Telehealth is the opposite of that. Telehealth is bringing healthcare to the patient, not the patient to the hospital or to the clinic, but that's where the incentive is. So again, we have a lot of work to do from the people who believe in the why of telehealth, as opposed to the payers and the lawmakers and the lobbyists. So, that's what we're dealing with right now.
Absolutely, and you raise a great point there. I think it's something that I certainly haven't heard mentioned in these sorts of discussions in terms of telling the patients to reach out to their legislators in that aspect, and how important that component is there. So we're going to move on to the next question, just in the interest of time here. So in terms of cost, what methods of virtual care delivery have been making the most sense right now? Sarah, do you want to start on this?
Sure. I think we've talked a lot about scale and the mechanisms by which you can achieve the greatest scale if your workflow and technology is buttoned up, and if the providers are supported appropriately and trained and all that. Asynchronous is incredibly powerful. Text-based is incredibly powerful. There are models and technologies out there that enable a single provider to engage with multiple patients at once. And so those types of things are out there in terms of efficiency. I think there's a separate question though around like whether physicians can, like, how do you build a model that isn't just feeling like so intense and churning through provider time? And there are some companies that appear to be getting it right, and some that are, and there's different ways to do that. For instance, taking a lot of the like admin type stuff and all the back office types of functions and the registration and the check-in and automating those kinds of rote things. And so, there are ways to support that, the work that sometimes the providers themselves have to do, and just generally creating like a technology infrastructure and some workflow that you build within that to be much more scalable. I think the question is less about like the cost and the efficiency and the scale, but it's more about building the system that works for the providers to deliver it sustainably over the long run. We can invent technology or workflow or whatever that quote works in the short term. I think that's less of a concern for me over time. It's much more about, it's really much more about the provider time that I think about, even though I'm not a physician.
Yeah, I'm going to add to that because I think, to build on what Sarah says, telemedicine is not about the workflows. I mean, it's not about the technology. It is about the workflows and the operations. And I know this is a controversial thing on a telemedicine panel, but if you're not doing value-based care, or you don't own the patient, the hospital, the ambulatory practices, and the providers, you're going to lose money right now on telemedicine. You're just going to. So we've looked for ways where we can compensate for that loss of money for the majority of our patients. And I would say the holy grail we found, and this would work for Abby and for Sarah, we have 35 to 40,000 employees. So we said, how are we going to save money on our employee pool? And so one of the things we did, which got us almost enough savings to pay for all of our infrastructure in 1 year, is we said, if you're going to go to the emergency department and you call our on-demand telemedicine platform first to get the emergency physician who would see you, and they send you to the emergency department, there's no copay for you. So you'd have to be silly to go without calling. Then when you call, 96% of the time, we can keep you out of the emergency department and get your care and coordinate outpatient testing. And since we pay for our own employees to go to our own emergency department, we could waive the copay and save all of that money and keep them out of the emergency department. And at a scale of 35 to 40,000 employees doing a bunch of calls a day, that has worked exceedingly well. And honestly, the savings the first year were about 40% of the cost of the whole program. So making the program overall revenue neutral or expense neutral to us, that was one of the major tricks we used. Anybody else making money in telemedicine on this panel?
Yeah, that's great.
For sharing.
I think Judd brings up a great point, though, which is that we are, in addition to what we talked about around advocacy, it's really aggressive advocacy and pushing with payers and other parts of the ecosystem for us to move toward value. I mean, that's really been a big part of the agenda. It's not just telehealth specific, of course, like that there are many drivers for that, but that's a really important part of what, what the system's work is to in part enable virtually enabled or, digitally enabled models of care.
We're going to jump to key takeaways here, just in the interest of time. So what's one thing, we always like to end on something tangible that our attendees can take away. What's one thing or consideration attendees should keep top of mind as they just try to work on building a smart, sustainable virtual strategy?
I would just agree that been very effective, but then when I think about solution model, deliver it differently.
I'm sorry, Abby. I think Abby, she said she's having some severe weather there. So we'll jump to Lisa if you want to give us your closing thoughts there.
Yeah, great timing as always, right?
I don't know, Abby must be having a hurricane or something.
For us, if you guys can hear me, I really think that we're focused in achieving scale, achieving high volume, achieving efficiency, really looking at different models of care that can work in different settings. So if you create a solution for hypertension, you want to be able to translate that solution to other chronic disease. If you're doing remote patient monitoring for multiple chronic illnesses, we want to be able to take that into a hospital at home setting. So really putting together foundational solutions that work for all of our employees.
All right.
To deliver that care to patients their end so that it feels like part of the healthcare that we deliver otherwise.
We got the response there. It came in on my end. I heard the full response. It was just a little delayed, but I heard it loud and clear there. All right. And Lisa, do we have anything to add there?
The only takeaway I would say that, yeah, all of these ideas are absolutely fantastic. And I love being a part of everything that's happening with the thought leaders. My key thing is just to maintain the momentum and really just say that we are not going back, that we are going to continue to move forward. It might be not at the pace that it was on March 10th, but I think that it's our goal, our mission is to keep telehealth rolling ahead in all of these wonderful ideas. And I do think it's sustainable. It might be not at the speed that we want, but it's going to continue. My big thing is the medical students. So that's what I'm going to start focusing on.
Absolutely. And going off that, I think it will be interesting to see, given all the challenges, when would become a part of the curriculum. And Dr. Hollander?
I think nothing in the world has ever changed because somebody asked the payers permission to change it. And I think we spend too much time sitting on our butts, hoping the payers will change the payment models so we could grow medicine. Not my area of expertise, but I'm betting the first angioplasty wasn't done after the payers said, I'll pay for angioplasty. And I'm betting the same thing is true with the first liver transplant. Probably the same thing was true with the first medical office building that moved away from a hospital. And we just need to do what's right for our patients. And if we do what's right for our patients, they're going to choose an employer or a payment model or a plan on the exchange that allows them to get the care they want. So I think my concluding comment is just do what's right. And with the lobbying and the advocacy efforts and with great patient care, everything else will follow. But we can't wait for the other things to happen first.
Absolutely. And last but not least, Sarah, you want to take us home here?
Sure. I would like to follow up a little bit on what Lisa said, which around pace. One thing that we have experienced over the last 18 months is a lot of momentum for telehealth and other digitally enabled care building, and a lot of the adoption and utilization challenges that we've had in the past, we don't have those anymore. And what that does is it raises the level of urgency, I think, especially as it relates to disruptive forces that are out there who usually have to do that hard work themselves. They don't have to do that hard work because everybody knows what telehealth is now, and many folks who had never used it before are now users. And so we saw, I think it was last week, the news that Amazon Care is pushing for Aetna to pay for its services. And I know many folks view Amazon Care with skepticism, but the point is that they're going after our patients and they are doing it with tremendous capital, tremendous will, tremendous amount of organization, and a lot of tailwinds associated with the hard work that the pandemic did for them. So I think there's a lot of urgency, and while we may not be used to moving fast, we really need to push our organizations to do so.
Sure. Well, that is all the time that we have left for today's session. Thank you so much again to each of our attendees for your time. We know very busy schedules. We really appreciate you sharing your thoughtful insight today. And also a big thank you to our attendees for taking time to be part of the Becker Shift to Digital event. Please be sure to check out also the other great sessions that we have going on during the forum, and do let us know if you have any questions or feedback. Thank you all again for joining us, and we look forward to having you at future Becker's events.